Salam alaikum. Dear chairmen, dear ladies and gentlemen, it's a great honor to speak here today on the African Health XCon. I remember the meeting last year and remember the innovation and the discussion which was in the room. And therefore, it's an honor to speak here again. The need for prevention programs is what I would like to touch, and I would like to come from the pathophysiology to the arguments why prevention is needed. Myself, Peter Schwarz, I'm Professor for Prevention and Care of Diabetes at the University of Dresden, and my heart is beating for prevention. My passion and my vision is prevention of diabetes, and not only the science, especially the translation into medical practice, public health practice, and also social practice. And what is unique about myself, I will be the next president of the International Diabetes Federation. From April 25, I will lead the International Diabetes Federation, and I'm member of the board of the NCD Alliance. All of them are dedicated to prevention of chronic diseases. To start with, we have to understand health determinants. And if we are looking where diabetes is currently coming from, you see here the prevalence of diabetes in the 80s, and blue is the increase in prevalence of diabetes due to the increase in population. But yellow and rosé is the increase in prevalence of diabetes due to the change of our lifestyle. And this is the key component. We have changed our lifestyle. And it doesn't matter in what country you are, it doesn't matter in what region you are. The change of lifestyle is driving the increase in prevalence of diabetes. And this is not an issue in Europe. Europe, we could say, is not having a health problem related to diabetes or prevalence of diabetes. The prevalence of diabetes is increasing in Asia and Africa. So from our side, the International Diabetes Federation, if we want to have an impact on prevention, we have to have it in Africa and in Asia. If you're looking at this slide, you may think this is the increase in prevalence of diabetes in the future. It is not. It is today the rate of air pollution. And I don't want to argue and now say climate change is also making diabetes, but there is a strong link. For example, if you stand behind a diesel car and you take a deep breath, the medium-sized particle out of the diesel engine can be found 2 weeks later in your insulin-producing beta cell. And of course, this may have an impact on the fluidity of the beta cell and beta cell function. So we have to learn about the health determinants, and I think air pollution in the future will be something to be addressed if we want to prevent diabetes from developing. And if you are looking where our people are dying from, most of the common reasons and determinants of premature death are related to diabetes, endocrine function, metabolism, and the next common ones are climate and air pollution. So if we think about prevention, we have to think globally and in a broad scale to address all the different risk factors. But many of us are physicians, we are scientists, we have to understand the pathophysiology. And here you see a CGM profile of a young woman with a high normal A1C, and she's eating a lot and is having the purple line as glucose, a flat glucose curve. Today we know this is healthy. This is someone needs very little insulin to regulate blood sugar. Everything is in order. Here is her father. It's also truly her father. And you see a better A1C, but a totally different curve. And in the morning and in the evening, it is similar to the daughter, but then there are this fluctuation of glucose. And why I'm showing this? Because today we know that this fluctuation of glucose drives morbidity and mortality of our patients. So imagine you have two patients with an A1C of 7. This is in the quality criteria for diabetes management. And one has mild fluctuation, the other one has a big fluctuation. The one with a big fluctuation will die because of a stroke and a heart attack. So we have to address this fluctuation. Lifestyle change is the most sufficient one. The difficulty is we don't find these people. I'm jumping back. This fluctuation in someone who is not having diabetes yet would be the ideal moment to do preventive measure, but we don't find them and have to think about alternatives or have to hope that in the future glucose sensors become so cheap that we can use them for screening. If we look into the pathophysiology, today we would say the visceral obesity is driving the morbidity of our patient. This is also true, and the argument for it is as more visceral fat you have, as more free fatty acids are released, and they develop insulin resistance, and there are more than 800 known peptide hormones secreted out of the visceral fat, and they make depression, they make dementia, they make an aggressive development of diabetes development. But there's a second player on the field since some years, and this is the liver fat. If you have 100 grams of fat in your liver, you become a non-responder for physical activity. But physical activity is the only measure to get the visceral fat away. So if you have 100 grams of fat in your liver, you become a non-responder to most of the anti-diabetic drugs. So this makes the treatment of people with diabetes who also have liver fat very complicated. We have seen this in the past, but we didn't know the reason for it. The logical consequence is to think about if we diagnose diabetes here and we as physicians come to act here, we should think about how we can act earlier to prevent diabetes from developing. And if you are looking at this, there is the visceral fat and the hepatic fat changing a lot. So the logical consequence would be to get visceral fat away and hepatic fat away to prevent diabetes from developing. As I said to you, the visceral fat is only going away by doing physical activity. But how the hepatic fat? The interplay between both fat compartments drives the development of diabetes. The visceral fat makes us sick. The hepatic fat is killing us. The visceral fat we get away by physical activity. The hepatic fat we get away by fasting. If you fast for 2 weeks without eating anything, you can totally abolish your hepatic fat. 2 weeks, no kilocalorie, no energy, no food, drinking a lot of water. So, for example, water diet for 2 weeks, and your hepatic fat is gone. In my eyes, this is the fastest gain of health we can generate and an effective measure for prevention of diabetes. If we use NAFLD as synonym for liver fat and differentiate obese and non-obese, having no liver fat and liver fat, and here is insulin resistance shown, an obese person, but without liver fat, has a better insulin sensitivity than a slim person, but having liver fat. So the liver fat is a driver of morbidity and mortality of our patients. And this was shown by Taylor a few years ago. If you have a lot of fat in the liver, you have it in the pancreas, and this destroys beta cell function. If you remove it from the liver, if you remove it from the pancreas, and this goes hand in hand, you can restore beta cell function, and this may lead to a remission of diabetes. So if I'm talking about fasting as a tool for prevention of diabetes, it's also a tool for remission of diabetes in patients who have already 10 years diabetes, and it still may work. And this is effective, not only fasting, also lifestyle change. A number of studies, about 50% of diabetes can be prevented by changing lifestyle, and this can be actually topped by fasting. But also drugs may work, but the drugs only work as long as you take the drug, and lifestyle change works with a sustainable aspect. So I'm not arguing pro drugs to use for prevention because it's an early treatment and not real prevention. But these 5 goals work to prevent diabetes from developing: body weight reduction, less energy intake, less fats, a lot of fibers and physical activity. And if you implement all 5 goals into your lifestyle, you have 100% chance of preventing diabetes. This is cool information. And we also have to understand ourselves, us as a patient, how we think. And for example, where is the problem coming from? If you think about soft drinks, and if you analyze 1 soft drink per day for 1 year, what it does with diabetes risk, and you see 380,000 patient years on this slide. If you drink water, it's healthy. It's not increasing diabetes risk. Orange juice and other soft drinks, 40%, like the Coke, 40%, the Diet Coke or Coke Zero, 60%. How can this be that Coke without sugar is generating more diabetes than the cola with sugar? And the answer are artificial sweetener. And the problem is, if you consume a certain amount of artificial sweetener, you change your microbiome. So you change the bacteria in your gut. And now imagine you are physically active and you drink a lot of artificial sweetener or eat a lot of artificial sweetener. It changes the microbiome. And this bacteria in the gut who invade the gut, there are 13 different germs invading our gut. They produce metabolites. These are fatty acids. They are saturated fatty acids, we can say as their stool, and we incorporate them into our bloodstream through the gut as the fat from tiramisu. But the problem is these fatty acids from this bacteria of the changed microbiome, they land in the liver, they are accumulating in the liver, and they make liver fat. And this let us become a non-responder for physical activity. So this is part of the problem. And this is something we can address. So this could be part of an effective prevention program. And my heart, as I said, is beating for prevention, prevention, prevention. And prevention sometimes can be easy. If you're walking 10,000 steps from the age of 22, you will not contract any chronic disease. And for someone who has diabetes, if he is increasing only by 1,000 steps, it's 600 meters. It's maybe walking from the room here out of the hall and coming back. It lowers the postprandial blood sugar twice as much as 1,000 milligram metformin are doing. So this is good information, but this is a reality what we are walking per day. And if I ask how many hours per day we are inactive, physically inactive, this is the answer. We are a lazy species. So we have to think about better ways, more intuitive ways of prevention. And smart health will help us, and it will be disruptive in some ways. Here you see how our oral anti-diabetic drugs lower A1C, how lifestyle is doing, and how digital tools are lowering A1C. So young digital tools have a very good impact on lowering A1C. And the answer is why we are in the pocket of our patient. We never have been so close to our patient than being in the pocket. Every one of us is taking 1,800 decisions a day. 450 are related to lifestyle. If we only influence 10 out of 450 in the right moment, with the right motivation strategy, with the right content, but do it over 1 year, it can be translated to 10 kilogram of weight reduction. So modern diabetology, modern prevention could look like this. And there's nothing against it because this can be the strategy where we reach people where they are and use the smartphone as a delivery channel for modern prevention. And there are good examples in Germany, licensed prevention and treatment tools, Vitadio, a type 2 diabetes prevention tool, using AI to analyze food items and helping the patient to change diet. Una Health and using the glucose sensor and using the sensor curve and doing a very precise nutritional coaching. And One2Diga also using the sensor and having 6 areas of preventive and diabetes care, and giving very precise recommendation what to do. This is the healthcare provider out of the pocket of your patient. Maybe not something which is needed in very developed healthcare systems, but in healthcare system with a good digital infrastructure, but gaps in the density of healthcare provider, these digital tools can be a game changer for prevention. And for example, analyzing the glucose curve, for example, if you have a cheap sensor, can help you to identify the strengths of the individual or the person at risk and helping them to use his strengths to change lifestyle. Digital biomarkers may change and disrupt our ways to how to find people. And there are a lot of digital biomarkers on the smartphones which can help us to identify people at risk, to feed back and visualize their situation, but then also using it for preventing diabetes from developing. And if you do this, it's only a very short step also for digital treatment and digital intervention for better diabetes care and prevention. So why should not the future of diabetes prevention look like this or look like this? And I think the International Diabetes Federation should be on the forefront in doing this. Finally, I would like to touch the fasting again. We know that eating less is healthy. Maybe we can say eating nothing for 2 weeks is even more healthy. In my eyes, eating nothing for 2 weeks, a water diet is the fastest gain of health you can generate. You lose a lot of weight, but especially you lose liver fat and pancreatic fat. You have a reset of the microbiome, and it's a very important personal experience. And here you see a sensor curve of someone after fasting. It's an ambulatory glucose profile, and you see such a flat curve as from the women I showed you at the beginning. So this, I will not say is a cure, but it's a disruptive intervention to gain health in terms of preventing diabetes. MRI spectroscopy, and you see the liver here, and all this white spot is fat in the liver. This is before fasting, and this is after fasting. I think this explains the efficacy of fasting. These are the recommendations: how to fast, how to go ahead, how to use it, how to stop the fasting again. And this is on a physiological level what you can reach if you do the 2 weeks water diet of fasting for diabetes prevention. I will be the next president of IDF, and I will fight for prevention and for digitalization in prevention, as IDF as a strong partner for this. Addressing the need of the people with diabetes or diabetes risk is my passion and my energy for every day's work. Why IDF? Because I think IDF can be a powerful voice in a global community for people with diabetes and diabetes risk. And I think everyone has the same right to have the same preventive and treatment measures, and this to get the same quality of it. And I think the mission is that we should provide, as all the people here in the room, that the people have also the same access and availability of the same quality of prevention and diabetes care. So putting a face on, a smile on all these faces of people with diabetes and diabetes risk is what should drive our everyday's work. Is this enough? Of course not. Don't forget the 10,000 steps. Walking 10,000 steps is good. Here you see all pedometer. Today, every smartphone has a pedometer pre-installed, and looking 3 times a day on the step count will make you walking 3,000 steps more the end of the month. But don't trust your physician. Here you see 31 diabetologists on the slide. German diabetes meeting. One is using the stairs, all the others the escalator. Airport in Doha, airport in Munich, airport in Dammam in Saudi Arabia, at diabetes meeting. These are we. We are not always a good example for our patients. Let's change this. Don't forget the 10,000, a clear yes for physical activity, fasting, and digitalization for diabetes prevention. And let's work together with all our intuition, our ideas, to finally help our patient to walk away from diabetes. Shukran. Thank you very much for your attention.